now. He's full-time researcher at the National Cancer Institute in Mexico. Now I'm going to give the floor to Dr. Corbalan.
Buenos días y buenas tardes, dependiendo la ocasión.
Morning, good afternoon. I would like to welcome you to this symposium. Yesterday, a lot was discussed about general topics and opportunities for research between Latin America and the United States. I think it was a very rich conversation to look into opportunities for collaboration now. I'm going to speak about prevention, screening, and early detection of cancer. The first session will be moderated by Dr. Brown. They are both GOTI directors. Nelson?
Sí, entonces comienzo a dar la bienvenida.
I'm going to welcome all of you for the first session of the second day.
Me gustaría invitar.
I would like to introduce Dr. Caterina Ferreccio. She will be the first panelist in this session. Dr. Ferreccio is full professor of the School of Medicine at the Catholic University of Chile. She is a director of the master's program in epidemiology in the Public Health Department. Dr. Ferreccio is assistant director of the Advanced Center for the Study of Chronic Diseases, and she is a renowned leader in epidemiological and population studies related to chronic diseases, particularly cancer. Dr. Ferreccio has taken part in the implementation of public health policies in Chile, and now is leading the first cohort for the study of chronic diseases in the south of our country, the Mauco cohort. Without any further ado, I give the floor to Dr. Caterina Ferreccio. Thank you, Nelson. Please let me share the screen in order to make my presentation.
Doctora Ferreccio, ¿se puede compartir su pantalla abajo?
Dr. Ferreccio, you have to share the screen yourself. Yeah, I've already done it. Can you see that? Yes. We can see it very well. First, I would like to thank the organizers for the invitation and the opportunity to share with several Latin American countries. This will be a review of several topics. I will give you some examples of research that we are conducting in cancer prevention in Latin America in the last years, a sort of selection. Of course, with an emphasis in what I've done. And here we have two concepts that are important for primary prevention, which is avoiding contact with the cause of the cancer, and secondary prevention, when the contact already exists, to be able to detect early the person that is affected, to avoid progression to more advanced cancer. These are the two areas I'm going to explore, and then a brief discussion. The first thing is primary prevention. When you review what has happened lately, the largest number of studies I have found in a very quick review till 2019. Here we have gastric cancer, then cervix and the other cancers were not so frequent. And what type of studies? The most frequent ones, well, there were studies coordinated by SWOG. The communication was done by Dr. Bob Greenberg. This was a comparison of 3 strategies to eradicate H. pylori. We call this primary prevention because H. pylori that colonizes our stomach only causes cancer in a small percentage of the population, not in everyone. So if you can eradicate the infection, you will prevent at least 75% of gastric cancer, at least in our countries, if we eliminate it. This is a study from Colombia. They go one step ahead and they analyze the result of the classic eradication, the tritherapy. And this is the host to see whether they achieved a better outcome when they modified the therapy scheme according to the capacity to metabolize that people had genetically. This is along the same line of eradication, but trying to use genetic information of the host to make a personalized intervention. This is another study, one of the few with a long follow-up. The question is the reinfection after eradication of H. pylori in patients with peptic ulcer. We saw that there was very little reinfection. 91% still had eradication after 5 years. The other area done in Latin America for primary prevention is to prevent infection with HPV, particularly 1618. And there are the most important studies in Costa Rica. This is a joint venture between the Costa Rican state and National Cancer Institute of the United States. This study is very important and was able to answer a question that concerned epidemiologists, which is knowing that there are several types of HPV which are oncogenic and that vaccines only aimed at 16 and 18 genotypes. The question was, if you remove from circulation 16 and 18 types, will other types occupy their place? This is a question answered by this project, saying that there is no replacement. You remove 16, 18, and so the burden of cancer is reduced for several years. This is very important. You know that Guanacaste is underway. It was expanded to all of Costa Rica. And they are studying how much one dose of benefit, could be beneficial, because this would cut costs in terms of prevention. We have also demonstrated Latin America. Here we have the countries that can do studies of vaccines in several countries, for example. This is the 9-valent vaccine. This is important for COVID. Probably those very same countries could take part in the assessment of vaccines. So there is that installed capacity. Another area of prevention is what has been led by Brazil, which is education, communication with the population, exploring different strategies. Brazil was the first country in Latin America that put those warnings on cigarette packages. What we can see here is a strategy for prevention of skin cancer. They used medicine students for them to go to schools to teach children how to what happens with the lesions on the skin as a result of sun exposure versus a skin that is not exposed to the sun. And they saw that children were able to take preventive measures. So it is very interesting. This is primary prevention for skin cancer. In Brazil, they have been leaders in smoking, and they used also the same strategy. You know that in Latin America, we are the first to acquire smoking at the time of the school age. Here, we have the strategy with the medical students. Here, we see how the control group, without intervention, women increase from one grade to another, the prevalence of smoking increases. The intervention group, well, there is no very big increase. So there are advantages with this intervention of the medical students. And males, the control group went up a lot. And in the group of males with intervention, we saw the benefit. So here we have the possibility of doing primary prevention with a focused education with peers that they admire. Now let's go to the other topic, which is secondary prevention. The contact with the carcinogenic agent was done, but how to do this secondary prevention? Here we have early detection of gastric cancer, early detection of cervical cancer, and breast cancer. Some of the most frequent examples in our region. And here we have the most studied cancers in Latin America: cervix, breast, colorectal, gastric, prostate, papilloma virus, other biomarkers, stomach, endoscopy, ovarian. So here we have a bit more diversity in primary prevention. I will tell you something that I had a chance to lead. This is a study we conducted in Santiago. 8,000 women, a bit more than 8,000 women. They were invited for a pap smear and simultaneously to get a sample to detect HPV. And we saw what happened with positive women at either exam. They underwent a colposcopy. So what I want to show to you is when women had a positive papilloma virus with a negative pap smear, 28 advanced lesions. This was detected. And here we have the opposite. When the papilloma is negative and pap positive, we found no high-grade lesion or cancer. And they are both positive. When they are both positive, we found cancers we couldn't find with HPV alone. This is a group negative to pap smear and papilloma virus. But there were lesions. Visual inspection found some alteration. This subset, they are both negative, and we found a cancer and a lesion. So we have to do this. And what I will show you here is the positivity papillomavirus and pap smear compared by age. Those under 25 and those over 60, the maximum of papilloma appears at young age. When women start their sexual life, they are exposed to the virus, and this goes down because there is an immune response. The virus doesn't multiply and it's not detected. The problem that we have with VPH, most of those infections maybe have no consequence. These are high-grade lesions or cancers that were detected at different ages with HPV and pap smear. You see that at all ages, there was more detection by HPV than pap smear. Since we have this excessive sensitivity, because it also detects subjects without lesions, what we assessed is what about the genotyping of the virus? Not only high grade, low grade, but 16, 18. What happened with that in this population? So we started with the 800 patients that had high-risk DNA, and we genotyped 776. When they were negative, how many lesions existed? We found 2 cancers and 14 advanced lesions. This means that there are other genotypes that cause cancer in our community. But when they were positive, one or the other, this is just 16, only 18, and both. Here we found 6 cancers, and we found many more advanced lesions than when they were negative. The N is bigger here. Now the N here is smaller. 16, 18 is a good triage, but it doesn't reassure us. The other thing we have that is very important is how to do the triage. 16, 18 alone wasn't enough. This program is quite ambitious. It's called the Stampa. There are several countries participating. The idea is to respond with an N of 50,000 women that have positive VPH to be able to identify the best triage to decide who should go to colposcopy. So here, just to show the countries that are collaborating, Honduras, Colombia, Paraguay, Bolivia, Uruguay, Argentina, Peru, Costa Rica, Mexico. Chile, we have collaborated in the design of this project that is very interesting. The good thing of a Stampa project is that it will leave installed capacity in Latin America because it comes with permanent training, quality control in screening, epidemiologically, pathologically. Another thing we have done research about is H. pylori and gastric cancer in collaboration with YAC, we have studied two places that are very different in the country. Antofagasta, with the lowest rate of gastric cancer, and Valdivia, the highest rate. H. pylori, practically the same prevalence, but the gastric atrophy measured serologically, we have just blood samples, we do not have endoscopy. We found that the main difference between Antofagasta is atrophy that is bigger at younger ages, between 45 and 54 years old. This is a Mexican study that is very interesting for early detection of colon cancer. Based on blood occult in the stools. 90% returned to FIT, 13% positive, and 10% will go to colonoscopy. And 0.9% will not have colon cancer. This is important for our countries to see the impact of colonoscopy. This is another study in Latin America, which compares sensitivity and specificity of PSA in type 3 cancer. You'd be much more sensitive, more precise than PSA to use PCA3. And there are other molecular studies in different countries in Latin America. This is the last thing. This is the last I'm going to present. Here, we see mortality to incidence ratio for several cancers in Latin America, Japan, European Union, and United States. What can we see? For breast cancer, we see that if we compare ourselves with the other three places, we have excess of mortality. We have more death for cancer comparing with the incidence they have. So more people die here of breast cancer. The same thing for cervical cancer. Ovarian cancer, the same. Prostate cancer, more die. Leukemia, liver, so-so, lung, too. Stomach cancer. We are much worse than Japan, for example, and worse than the United States. And now, the fact that more die is because we do very poorly as clinicians, or patients are arriving late. I think that is the case. Now, the conclusion. Cancers we're studying the most in Latin America, which is in agreement with the cancers in the region, are stomach, cervix, breast, colon. We have higher mortality, and this is probably because patients are arriving at an advanced stage of cancer. So there is a failure of primary prevention. My conclusion is, in order to overcome this problem, we should move forward and do early detection with operational research that improves current programs. For example, papillomavirus program. It has not been fully implemented in Chile. We continue with pap smear. It is necessary. We have to propose new strategies that are evidence-based But the most important thing in this environment is that study design is to be done in such a way that results are feasible to apply, that are possible and feasible to apply in the local population. It makes no sense to do studies with designs that won't be replicated. Thank you very much. Thank you, Dr. Ferrecchio. Thank you, Caterina, for your presentation about research in Latin America. Very important studies in the region. The second panelist is Dr. Marianne Neuhauser, is full professor, and she leads the program progression, and she's at the Fred Hutchinson Research Center in Seattle, United States. She's a member of the Faculty of Nutrition Sciences and affiliate professor of epidemiology at the Public Health School at the University of Washington. She has ample experience and leadership in prevention clinical trials, including Women's Health Initiative and prostate cancer prevention trial, dietary interventions, and large observational cohorts. She has participated as a principal investigator or co-investigator in several research projects funded by the National Cancer Institute. She has more than 350 publications. She's co-director of the Prevention and Epidemiology Committee of SWOG. Welcome, Dr. Neuhauser.
Good afternoon. Can everyone hear me all right? Okay.
Yes.
Perfectly. That was a wonderful presentation, but by Dr. Federico, and I'm delighted to follow up her presentation right now. So you might wonder, why are we having a talk on cancer prevention within an organization such as SWOG that's focused on treatment trials? And I think the first presentation really pointed out some of the value of prevention and the importance. And overall, the underlying rubric about prevention is that if we can effectively prevent individuals and families from getting cancer in the first place, then we can make progress towards the mission of reducing suffering and death from cancer. So what is cancer prevention? Cancer prevention is action taken to lower the risk of getting cancer in the first place. So some examples include developing and maintaining a healthy lifestyle through diet, physical activity, weight control, avoiding exposures to known cancer-causing substances. And the first presentation talked a bit about tobacco. There's other things such as benzene, asbestos, many chemicals, taking medications or vaccines that can prevent cancer from developing, and removing precancerous lesions. The goal is to delay or intercept carcinogenesis, reduce suffering, and healthcare expenditures. So cancer prevention research develops and tests interventions with the goal of turning discovery into evidence-based practice to benefit the larger population. A useful way to think about the value of prevention is to think about the population attributable risk. So the population attributable fraction is the proportion of cases that would be prevented if the exposure was removed. And this is an example using obesity. It shows the worldwide population attributable fractions of new cancer cases due to high BMI or obesity. In the top in blue is males, and in the bottom in red is females. So we can see even here in Chile, among males, between 3.1 and 5.5% of cancer cases could be reduced if we eliminated obesity. And among females, it's a bit higher, 8.5 to about 12.7% of cancer cases could be eliminated if we eliminated obesity. So that's the value of population research. There are 4 types of approaches to cancer prevention research. The general population, this is most people who are at average risk, elevated or intermediate risk, high risk, and secondary prevention. Today, we're going to focus mostly on general population, which is average cancer risk. And these are the types of things that are useful for everyone, such as pap smears, mammography, colonoscopy, FIT tests that were talked about in the first presentation, vaccines, programs and policies to reduce availability and use of tobacco, and limiting sun exposure, which was also mentioned in the first presentation. And then also those who are at elevated or intermediate risk, for example, people who test positive for H. pylori, someone who's had a prior colon adenoma or abnormal pap or mammogram, known genetic risk factors, chemoprevention for prior LCIS or atypia, and even prophylactic surgical interventions. Those are useful for people at elevated or intermediate risk, but not necessarily the general population. So in the general population, we first start with etiology. And this is how we understand the extent to which cancer biology, environmental exposures, and lifestyle factors may slow or arrest the growth of tumors from initially transformed cell clones or precursor lesions. And detecting colon adenomas or polyps is a very good example of how this is done. When the colon polyps are removed through a colonoscopy, then that essentially interrupts the process. We could also think about preventive interventions. And this is where we modify the environment or modify lifestyle exposures. And these are very actionable and often very cost effective. For example, many smoking cessation policies, either in the workplace, parks, restaurants, those are very low cost interventions to implement and policies to implement, but they can have a very wide ranging effect on the general population. Prevention studies in the general population have a large reach. They really have the potential to reduce cancer suffering and healthcare costs in a large number of people. And many of the examples are listed here, and they were also covered in the first presentation. These have high generalizability. So essentially, we get a high rate of return on the investment. Some other advantages of doing prevention studies in the general population is that we usually see other benefits of cancer prevention on other health systems. So there's typically improved cardiovascular and metabolic health when people stop smoking, lower the obesity rate, and improve their diet and physical activity. It also improves diabetes risk factors in addition to cardiovascular risk factors. There can also be improved occupational conditions, which results in worker satisfaction. So if workers are exposed to fewer contaminants such as asbestos and pesticide, if they have reduced pathogen exposure in the workplace with a safe water supply, smoke-free workplaces, and access to safe, healthy, and affordable food in the workplace and schools, that improves overall working conditions and worker and citizen satisfaction. Challenges of doing cancer prevention in the general population is that even though those of us who work in cancer, especially clinicians, you see this every day, so cancer probably doesn't seem like a rare event to you. But when we think about the population, we still have to realize that cancer is a rare event. So in the United States, here are some of the numbers for the annual incidence rate for total cancer, breast, colorectal, ovary, and myeloma. So the implications is that when something is a rare event in the large population, often we have to have a lot of data to do very high quality studies. And then for rare cancer, such as myeloma and something like cholangiocarcinoma, it's very hard to do those studies because it's hard to identify enough high-risk individuals to understand, first of all, what the etiology is, let alone what's an effective prevention. Other challenges is that we need a large sample size for large prevention trials, usually in the tens of thousands of participants. We have to understand what should be the appropriate eligibility criteria, Are there underlying risk factors that we need to account for in assigning intervention and control arms? And then what's the endpoint? Should the endpoint be cancer, which often is many years in development? Or can it be a surrogate endpoint, such as a precursor lesion, such as a colon adenoma, a biomarker such as mammographic density? One of the challenges is we don't have a lot of really good biomarkers. On the other hand, we'd like to have cancer endpoints, but that can take many more years, making these trials long, expensive, and logistically challenging. We also have to think about the fact that preventive interventions must be very safe. Chemoprevention can include dietary supplements, and some of these, such as PCPT and SELECT, those have been SWOG-led studies, vaccines, lifestyle interventions such as smoking cessation, dietary modification, and so on. And then there has to be consideration to what's the placebo going to be? What will be used for the placebo? Is it just usual care, or is it a pill or a shot that's the placebo? A challenge with usual care is that usual care changes over time. And we're seeing this now with some of the digital mammography screening trials, that usual care is moving towards digital mammography, so it makes that trial very difficult. And then for lifestyle modifications, such as smoking cessation, physical activity, and diet interventions, often there's drop-in for people who were not randomized to the intervention arm. Additionally, in cancer prevention research, we must be very careful that the prevention trials do no harm. And we have had some unexpected results in prevention trials. The carotene and retinol efficacy trial and the alpha-tocopherol beta-carotene cancer prevention trials tested high-dose beta-carotene dietary supplements, and both of those trials ended early due to harm. SELECT, which was led by SWOG, tested a vitamin E and selenium supplement that also ended early. And then about 15 or so years ago, there was a trial testing COX-2 inhibitors. That trial also ended early. So we have to think about balancing the potential benefits and the risks. There may be modest increases in more common health conditions, and perhaps that can outweigh benefits for rare conditions. So who are the intermediate and high risk groups in Chile? Now turning to the second part of what we're going to cover today. What approaches should be used to identifying these high risk groups? Should it be based on trying to find people with certain exposures, such as pathogen exposures to HPV and H. pylori? How do you find those people who are positive or who are at risk? Occupational exposures to heavy metals, how do you find those people? Particulates, obesity, smokers. How do you find people with those exposures and enroll them into trials? How do you find patients with a strong family history of cancer? Do you use genetic testing? And remember, the screening and testing is only effective for prevention if there's actionable follow-up. Patients with precursor lesions, such as colorectal adenomas, mammographically dense breast, low-grade prostate cancer. How are those people identified in the clinic setting and enrolled into appropriate trials? One thing that can be used for intermediate and high risk populations is risk prediction modeling. So this is where patient information is used to predict a patient's risk of a future event, in this case, cancer. So some examples of using biological data and patient information in the past have included using a patient's LDL cholesterol level and their blood pressure levels to predict future risk of myocardial infarction or stroke. Those types of models work quite well. We also know that mammographically dense breasts predict future risk of breast cancer. And for genetics, there's multiple approaches to using genetic data to predict cancer. Most of those models have been used for colorectal cancer and breast cancer, less so for less common cancers. So many of these models take information on family history, reproductive history, personal medical history, and other exposures, and the biostatisticians build, test, and refine the models. So risk prediction can be very useful because it can identify who should be screened. For example, who should get a CT screening for lung cancer, who should get colonoscopy versus a FIT test, who might benefit from preventive interventions. For example, if someone has a Gale score greater than 1.67, it may be recommended that they have annual mammography before age 50 and consider other imaging such as breast MRI once every few years, or at least to get a baseline, and even considering chemo prevention with tamoxifen. Risk prediction can also help identify who might benefit from more invasive prevention efforts. For example, prophylactic mastectomy and bilateral salpingo-oophorectomy. Also, which relatives would benefit from screening? If risk prediction suggests that the genetic component is particularly strong for an individual, perhaps their first and second degree relatives would also benefit from enhanced screening. And then finally, risk prediction can be very useful for predicting risk of recurrence or secondary prevention. For example, the Oncotype DX recurrence score is quite useful. Now, it's very important to remember that risk prediction is prediction only. It does not predict cause and effect, but it can guide clinical decisions for patient care. So that's where it's a very useful tool. Challenges of high-risk cancer prevention includes that many of the laboratory tools and technologies are not available for clinical practices in community oncology. They're only available in the academic medical center setting. Discovery studies of biomarkers and technologies have not been as fruitful as we hoped, but there's a new SWOG study S1823, and we are hoping that this will yield very good results in terms of being a predictive biomarker for germ cell tumors. There's also a lot of heterogeneity of tumor biology, so trying to predict how a tumor is going to behave in the high-risk population is a challenge. And then, as was mentioned in the first presentation, not all precursor lesions develop into cancer. Not all HPV leads to cancer. Not all low-grade prostate cancers, breast atypia, small polyps, and so on lead to invasive disease. And that was very nicely presented in the first presentation. So
4 minutes remaining.
Risk prediction is not perfect. There's a lot of uncertainty, but it can be a very useful tool. Some other things to consider for prevention research in high-risk populations is participant recruitment. Just like with the general population studies, we need to determine what's the eligibility criteria, what's the exclusion criteria. We don't want to have so many exclusion criteria that it makes it very difficult to recruit, and yet we need to have some integrity of the results as well. Also, how do we obtain the risk information? Should it be obtained from medical records, referrals from general medicine, general population announcements? How is that information obtained? And then, of course, reaching adequate numbers of participants who are at increased risk. Exposure assessment is very complex, regardless of whether it's the general population or those at elevated risk. For example, we've already talked this morning about H. pylori and HPV. Are there other pathogens besides those, and besides the well-known Hep B and C infectious agents that may predict cancer risk? Are there interactions of these exposures with germline genetics or other exposures? And then in the high-risk population, randomization to a control group may be problematic because if someone's at high risk, they may not want to be in the control or comparison group, and results can be less generalizable. So in summary, prevention trials have different goals and use different methods than treatment trials. There's a potential for large population reach, improved population health, and reduced healthcare expenditures. Moving evidence to practice can be very challenging. It takes quite a bit of evidence, a level of evidence for moving things along. The strengths and limitations of cancer prevention trials in the general population and intermediate and elevated risk individuals described. But again, our overall goal is to interrupt the cancer process before it starts or is irreversible. We want to reduce suffering, death, and healthcare costs. Thank you.
Muchas gracias, doctora Newhauser.
Thank you, Dr. Newhauser. Thank you for this very interesting presentation about clinical trials in relation to primary and secondary prevention. I would like to remind you that you can write down your questions down below on the right side in the Q&A icon, particularly during the discussion at the end of the session. Having said that, I'd like to introduce our next speaker, Dr. Garnet Anderson. Dr. Anderson, she's currently director of the Division of Public Health of the Fred Hutchinson Cancer Research Center, and she is a principal investigator at the Center of Clinical Research at the Center of the Initiative for Women, and she is also at the SWOG Statistical Center. Dr. Anderson, she is well known because of her leadership in the Women's Health Initiative, the WE, an effort to reduce cancer risk, cardiovascular diseases, and fractures related to osteoporosis in postmenopausal women. Her report, published in 2002, has given rise to a reduction of more than 50% of hormone therapy use in the United States, which has contributed to a reduction of the breast cancer rates and has also contributed to spare a lot of money in medical care in the United States. With no further ado, I would like to invite Dr. Anderson to give her presentation.
Well, thank you very much for that kind introduction. And hello, everyone. I'm so thankful for the opportunity to present to you today. And I'd like to thank the organizers and sponsors for their efforts to make this symposium happen. I've been asked to speak about group randomized trials because I believe they are used commonly for some prevention trials. And so I just want to say that I will use the term cluster randomized versus group randomized because I tend to say treatment group and I don't want to confuse the two concepts. So as a brief outline, I'll define cluster randomized trials and describe their motivation and give a couple of examples from SWOG. I'll summarize key design options and review the main protocol components that require modification. Saving the best for last, I'll go over the impact of cluster randomization on the statistical considerations and reporting. So cluster randomized trials are experiments where predefined groups of people, rather than the individuals themselves, are randomly assigned to treatment groups or treatment or intervention groups. These clusters may be defined by their social structure, such as families, clubs, or churches. They may be based on formal institutions, such as schools, workplaces, or clinical practices. Or they could be geographic areas, such as communities, political units, or catchment areas. When would we consider using a cluster randomized design? The most compelling motivation comes from characteristics of the intervention itself. An intervention that is naturally delivered at the cluster level, such as a new technology to be used by a clinic, or an intervention that manipulates the social or physical environment, such as a policy to prohibit tobacco use in a workplace, or the introduction of fluoride into a water system, could be tested in a cluster randomized trial. Sometimes we expect the intervention to work better because of the social support within a cluster. An example of this could be an intervention to improve nutrition through changes in diet, which may be best delivered to entire families. Concerns about contamination between the intervention and control groups can be a motivating factor. If clusters are likely to share intervention information or other materials, it would be preferable to have them all in the same treatment group. Convenience, practicality, and cost may also lead one to choose to deliver an intervention at the cluster level. And in some circumstances, one may find it unethical to treat members of a cluster differently than others. So cancer treatment trials would rarely be considered for cluster randomization, but primary and secondary prevention trials present many opportunities. SWOG has 2 ongoing cluster randomized trials that I would like to highlight. The first is S1415, which we call the TRACER trial. Led by Dr. Scott Ramsey, this trial is asking a practical question about preventing febrile neutropenia, a serious adverse effect of chemotherapy. Colony stimulating factor, or CSF, is effective for treating and preventing febrile neutropenia. The American Society for Clinical Oncology has developed guidelines for prophylactic use, recommending that high-risk patients always get prophylactic CSF, and low-risk patients do not get it. But there are no specific recommendations for the intermediate risk group. So the TRACER trial is asking 2 questions. The first is whether incorporating standing orders based on these guidelines into a clinic's electronic health record system would reduce the risk of febrile neutropenia and increase adherence to these guidelines. The trial will also answer a second question in the intermediate risk group. Would standing orders for prevention with CSF in the intermediate risk group improve health outcomes? This is the TRACER trial schema. Eligible community oncology sites were randomized either to control, where they follow their usual care practice, or to the intervention group, where standing orders for CSF were incorporated into their electronic health record system according to these guidelines. Among the intervention group, there was a further randomization to address the second objective. Half of the intervention group was randomized to have standing orders for prophylactic CSF use in the intermediate risk group, and the other half did not. A second SWOG example is S1904, led by Dr. Catherine Crew from Columbia University in New York. The decision support trial is similar to the TRACER trial in that it is using a technology to promote prevention. The basis of this trial is the fact that both tamoxifen and aromatase inhibitors have been shown to prevent breast cancer in high-risk women, but the use of these agents remains low. This trial will evaluate 2 tools to promote knowledge and improve decision-making by patients and their providers about chemoprevention. Dr. Crew and her colleagues have developed a website geared specifically to women. This tool, available in both English and Spanish, provides information to help women understand their breast cancer risk and the options for reducing it. They have a parallel decision tool developed for physicians to provide information on risk assessment and prevention so they can better discuss these topics with their patients. So this is the trial design, which defines a cluster as the community oncology clinic sites and any of their affiliates which share a single electronic health record system. Eligible patients in clinics randomized to the control group receive standard educational materials. Patients and their physicians in clinics randomized to the intervention group are given access and encouraged to use the websites. And the primary outcome is the rate of chemoprevention informed choice at 6 months. So I'd like to review some of the design options for cluster randomized trials. CRTs may use any of the variations available in individually randomized trials. They can compare multiple interventions simultaneously using either direct pairwise comparisons or in factorial designs, which allow one to examine potential interactions. Crossover trials, where each cluster serves as its own control but in a randomized order, may also be appropriate in some settings. A design not usually considered in individually randomized trials is the reciprocal control design, which tests two unrelated interventions on two independent endpoints. Each cluster gets one of the two interventions and is the control for the other. Another design unique to cluster randomized trials is the stepped wedge design. So far, we've been thinking about the parallel designs where each cluster is randomized to intervention or control when their eligibility is established, and follow-up continues in that assigned group, as shown here on the right. In the stepped wedge design below, all clusters start in the control group, and then they are randomly assigned a time to enter the intervention group. Now, some people have called this a design of last resort because of some of the limitations inherent to this design. There is a strong assumption of benefit since all the clusters eventually get the intervention. There is also concern for selection bias and time trends, since time and randomized order are confounded. However, it is a pragmatic design, and it's increasingly commonly considered for dissemination and implementation science trials, and it may be very reasonable for establishing effectiveness and cost effectiveness in real-world settings. Now I'd like to talk about some of the sampling design options. Our usual approach is a cohort design where all eligible individuals in the cluster receive the assigned treatment and are assessed for trial endpoints. Both the tracer trial and decision support trial use the cohort design. A second option is a cross-sectional design. This is usually used when the cluster size is very large and the expense of measuring the endpoint in all of the cluster members is not justifiable. Here, one simply randomly samples a sufficient number from both the intervention and control clusters at trial conclusion. You will see this design used most in large-scale public health trials, such as the one cited here. In launching a cluster randomized trial, each of the basic elements of the protocol require some brief modification, which I'll touch on here. Eligibility must be defined at both the cluster and the individual level. This example from the tracer trial is illustrative. At the cluster level, eligibility typically focuses on willingness to participate and accept the randomized assignment, feasibility of implementing the intervention, and cluster size. Individual level eligibility criteria resembles what you would expect to see in an individually randomized trial. Ethical considerations in a CRT can be challenging, but the basic principles of consent still apply. Again, there are two levels to consider. The nature of the consent process for the cluster depends on the type of intervention and the type of cluster. One must determine who in the cluster has the authority to authorize consent. Then one must recognize that the cluster consent doesn't mean that an individual consents. For this purpose, it's often useful to separate the idea of being subject to the intervention versus actually providing personal data. The basic principles of randomization still apply in a CRT, but since the size of clusters randomized is usually small, we typically rely on very simple randomization techniques such as blocking to assure balance between treatment groups over time. It is important, however, to keep details of this procedure known only to those conducting the randomization, so that no one can guess what the next assignment will be. Pairwise matching of clusters based on cluster size is often considered, but stratification into a smaller number of cells is preferred because it's more robust to dropouts. In a match pair design, one member is randomized to each treatment group. But if one cluster drops out, you lose the entire pair. With stratification, you retain information from that cell as long as there's at least one cluster in both groups within that cell. Blinding is, of course, a valuable feature in randomized trials, but its feasibility is highly dependent on the nature of the intervention and often not practical. Nevertheless, it may still be possible to blind study staff who are collecting endpoint data to the randomized assignment. This helps to ensure unbiased data collection. Regardless of that, one needs to have high quality endpoint data. This means high response rates that are comparable across the treatment groups. In a cohort design, efforts may be needed to keep the control group engaged, as otherwise those individuals may forget they're part of the trial and lose interest. In a cross-sectional design, one needs to be unbiased in determining who should be sampled. In particular, no data from the intervention itself should be used to establish eligibility for sampling. And now, what are the statistical considerations for a cluster randomized trial? So clustering impacts the statistical design and analysis through its effect on the variance of our statistics. The underlying assumption of clustering is that the cluster members are more similar to each other than to other people selected randomly. The level of similarity is expressed through a statistic called the interclass correlation, sometimes written as ICC or the Greek letter rho. It takes on a value between 0, indicating no similarity, and 1, representing perfect harmony. So this clustering makes the data kind of chunky, not so smooth. This chunkiness reduces the degrees of freedom and increases the variance of the group level statistics. If this clustering isn't accounted for in the analysis, the type 1 error will be too big, and this happens even with very small levels of the interclass correlation. So how do we adjust for this? First, I want to step back and remind you of sample size calculations for a simple individually randomized trial where the goal is to compare two means. This is the formula that one would use, and it's based on several parameters: the type 1 and type 2 error that one chooses, the sum of the variances in the two groups, and the differences in the means that one is hoping to be able to detect.
5 minutes remaining.
Thank you. Now suppose we plan to randomize K clusters with an average of J individuals per cluster and an interclass correlation of rho. This is the formula that you would use, which has the same formula we saw before, plus a new term. So the total sample size we need, given by n sub k, is really the total needed for the simple individually randomized trial multiplied by this component here, which is called the design effect or the variance inflation factor. And we know that this variance inflation factor is always greater than 1, which means nk is always greater than equal to ns. Once we calculate the nk, the number of required clusters, k, can be calculated as the simple ratio of the total sample size divided by the average size of the clusters. The same adjustments can be applied to power calculations for binomial outcomes. So these calculations rely on the interclass correlation. How do you calculate it? Well, one way is to use a partitioning of the variance. The total variance in a population can be written as the sum of the within cluster variance and the between cluster variance. If given that, the interclass correlation may be simply calculated as the ratio of the between correlation between cluster variance and the total variance, as shown here. When thinking about power calculations, it's important to recognize that that increasing the size of the cluster only helps to a certain extent. As the blue line on this graph indicates, increasing the size of cluster improves power a lot on the lower end of the cluster size. But at some point, the power curve levels off, providing little increase in power, even for substantial increases in cluster size. A few other notes to be aware of. If cluster sizes are highly variable, additional adjustment of these sample size calculations is needed. This reference provides some options for doing those. Cluster dropout can have a significant effect on power, so efforts to make the trial robust to this problem are certainly warranted. And cluster randomization does not necessarily eliminate the potential for cross-contamination. So this may need to be considered in the design as well. The starting point for statistical analyses for cluster randomized trials is the same as for individually randomized trials. The intention to treat principle still rules. Analyses can be based on randomization methods, such as a permutation test, or statistical models, but either type must acknowledge the clustering to assure that the type 1 error is not inflated.
2 minutes remaining.
One simple approach, thank you, is to create a summary statistic for each cluster and then analyze the clusters as independent observations. For model-based assumptions, one can use an analysis of variance or ANCOVA models for Gaussian distributions. And for binary or survival data, one can use mixed effect or generalized estimating equations to account for clustering. Finally, when presenting trial results, note that the consort guidelines for trial reporting have been expanded to address the issues of cluster randomized trials. These guidelines describe the additional detail needed on each topic. I recommend consulting their checklist when actually developing the protocol initially, because it will help assure that all of the points are thoughtfully addressed. In summary, methods for cluster randomized trials derive substantially from those for individually randomized trials. CRTs are most often useful for interventions naturally delivered at the cluster level. This clustering effect, known as the interclass correlation, must be acknowledged in both the trial design and the analysis. And finally, reliable and interpretable results can only be achieved by approaching the design, implementation, and analysis with the same level of rigor as one would use in any other trial settings. Thank you, and I'm happy to participate in the rest of the panel.
Muchas gracias, Garnet, por una presentación muy clara sobre un tema muy
Thank you for your clear participation. I would have loved you to have been my teacher of biostatistics, but it wasn't the case. We're going to start the roundtable now. You can write down your questions on the icon question and answer. We have half an hour for the roundtable. Nelson, would you like to ask the first question?
Dana Sparks pregunta ¿dónde
Sparks asks, where do you see the best opportunities for collaboration in terms of prevention between SWOG and Latin America? In what areas? I imagine it's a question for all of the panelists. In what areas do you think we can find the best opportunities for prevention where SWOG and other Latin American institutions can intervene?
I can answer if you wish. what I can see, what I would say, what we need in Latin America is an organization filtering, for instance, all the biomarkers that have been published or that are proposed, an organization that could filter which of those are really promising or have already reached a level at which they can be used for a serious populational trial. Because I think it is not easy to read and correctly interpret all the publications that we have today on biomarkers. There are thousands on bioenhancement. Well, so I think that SWOC could provide that service, like say, look, for stomach cancer, what is promising is this and that, for cervical cancer, this and that, and accompany us in the design of valid trials that could have an impact in a region. That's my answer.
No sé si la doctora Newhauser quiere,
I don't know whether Dr. Newhauser would like to say something about this.
Certainly. So I'm wondering, Dr. Federico, if the biomarkers you're referring to are biomarkers of response to an intervention or biomarkers of exposure, what kind of biomarkers are you thinking about?
Well, it's in general like biomarkers for screening, the mainly used. There is or screening or even mainly screening for as a risk factor.
Mm-hmm.
Let's say for triage. For instance, you have a patient with H. pylori, but you want to know if he may have the real need to go to endoscopy. So since endoscopy, all these procedures are a problem in Latin America: endoscopy, colposcopy, colonoscopy. So we need some triage that will decrease the volume that is received in the secondary level. But there is a lot of markers that are being published every day. So to have like an organization that would say, well, you know, this is the proper one because it has the strength and they're well designed and etc. Something like that.
Yeah.
And also help us finding the.
I think that's very good. And as I mentioned in my presentation, some of the biomarkers have not been as predictive as we would like, but that maybe would be a very good exercise that you were suggesting to try to understand what biomarkers have the best predictive value for cancers that are common in Latin America. And maybe wants to reply as well.
I would echo that. I think work in the US maybe has focused on cancers that are more common here and not so much on stomach cancer and some of those that are maybe of particular interest. So I'm not sure that work from the US is going to be that far ahead of you in that regard. I think overall, it's been surprising how few biomarkers have really advanced to the stage where they're ready for large scale trials. So I think there's still room for biomarker discovery. Mm-hmm. And you may have a patient population that would be very good to use for discovery kinds of science.
Yeah. Maybe I can ask something. Another example that is very urgent here is for lung cancer screening, for instance. We're not doing any lung cancer screening, and we have a region in the country with very high rates of lung cancer associated to arsenic exposure. The thing is, how do you screen? So we were some years ago with a colleague from the US, from NIH, trying to propose a screening based on what you learn in the US, but The problem is the training that you require to do low dose scan to be able to interpret. So we have a training required in the radiologist, and then very important in the person who is going to take the sample of the nodes. So also that will be also a very important prevention trial for in the high risk group of lung cancer that are exposure to chemicals or smokers, for instance.
Mm-hmm.
And we don't have that in the Latin America in general. Yeah, yes,
Now, you
examples.
mentioned the training of the radiologist. How about the actual equipment to do a spiral CT? Is that also in short supply?
Well, probably in most places it will also be in short supply, but in this region of Chile, for instance, we do have the equipment. We don't have the capability, the practice.
Mm-hmm.
So the equipment is not so difficult to get. You buy it once. You know, it's like,
Bueno,
but
vamos
that
a
is
seguir
something
con
that-
otra pregunta, porque tenemos varias preguntas
We will
llegando.
continue with another question because several questions are coming. This question is for Dr. Anderson. How can you interpret the information of cluster trials in other populations, in particular in Latin America?
So I'm interpreting the question as, are these results generalizable from one setting and cluster to another? And I think one would have to be very careful. So if you did a cluster randomized trial in a school system, you would have to understand whether there's enough commonality in the schools to transport that, say, curriculum or whatever to another setting. And so it would have to be very, each trial would have to be examined in that sense to understand where the limits of generalizability.
Gracias.
Thank you.
Vamos a seguir con
We're going to continue with other questions. Many are coming, and it is difficult to choose which one to prioritize. Gelda Leal asks, Dr. Ferreccio, in your studies with BPH, have you had experience with the presence of co-infection with other genotypes? And if so, how have you handled the situation, especially in regions where the prevalence of papillomavirus could be different from the genotypes included in the vaccine? Gilda Leal is from Mexico. Inglés.
What happens is that all high-risk viruses need the same management. It's only that you can give them a highest priority because they can evolve faster. But all the high-risk ones should be managed in the same way. 16, 18 are more aggressive. And in Africa and Latin America and everywhere, 6, 17, and 18 occupy or are responsible for the largest amount of cervical cancer, and this has been so all over the place. If we have other types, maybe some wouldn't be covered by the vaccine. We have the 16 and 18. So this is why we say that even if the population is has received the vaccine, you will need a screening, maybe not so frequent, but you will need some kind of screening with a bivalent vaccine. I don't know if Dr. Neuhauser would have something to add.
Do you have anything to add?
Yeah, can you repeat the question?
Oh.
in English.
Okay. So the question was for Dr. Ferreccio regarding the studies on BPH. Do you have experience with the presence of co-infection with other genotypes of this virus? If so, especially in regions where the prevalence of infection is very high, how these newcomers, new virus genotypes can be included in the vaccine? Or
Yeah, I think that's a very good question. And I think that Dr. Federico covered the answer quite well because the vaccine has changed a bit over time and now is, the non-valent vaccine. So as new discovery knowledge comes in about the oncogenic variants of the vaccine, then the components change. So it could be that the current vaccine that is commonly used won't be the last one. It could, change based on additional discovery and knowledge that is done.
Okay, hay varias preguntas ahora sobre...
There are several questions about lifestyle studies. A question is whether special strategies are required and how can you make sure that this change in the lifestyle remains in the long run? That question is more to Dr. Neuhauser, but I know that Catherine has a lot of experience in those studies.
Yeah, I can start, and then Dr. Federico and Dr. Anderson can add. Maintaining a lifestyle change is one of the most challenging things that we have in lifestyle intervention trials. Most of the trials show that there's quite a bit of participant behavior change in the first 6 months of a trial. And then there is almost always drop off between 6 and 12 months. And most of these trials are about a year length of time, although some, such as the Women's Health Initiative, were on average, 8.5 years. So to do sustained behavior change typically requires a more intensive intervention. Some of the less intensive interventions that might be delivered, on an app or a website or a lot of self-motivated change, that's harder to maintain and sustain. And I think something else that we are also beginning to appreciate a little bit more in lifestyle change interventions is something called the socio-ecological model of health that supports the fact that there are many influences on someone's behavior, whether it's smoking, physical activity, diet, drinking, other lifestyle behaviors. So there can be individual change and individual choices, but someone's lifestyle behavior is also influenced by their family, their work environment, the school, what kinds of policies local cities and communities have about that lifestyle change. So we really need holistic models to have sustained change, because individuals can make a change even if someone, let's say, for example, is successful on their own about smoking cessation. If they're in a workplace where smoking is allowed, or if they're in a community where there's a high degree of smoking, it's going to be very hard to sustain that change. So we need these large interventions that address all those levels. So now Dr. Federico probably has things to say as well.
I absolutely agree with you. I want to say that what you just described is more dramatic in our very poor resources environment. For instance, a small town where we have our cohort near where Dr. Brown lives in Molina, people don't have the healthy diet. They cannot. There is nowhere to buy it. And they cannot run or be on the street doing exercises because they can be bitten by a dog or they can be robbed. So what we say in this environment, if we don't change the conditions that will allow the behavior, the behavior will not occur. So in Chile, the same government that we have now, but in his first presidency, his wife put this thing that choose to live healthy, elige vivir sano. And I said to them in the Ministry of Health, why don't you change it to Chile, elige vivir sano? So Chile choose to live healthy. Because you cannot ask the individual if all the environment goes against you. So that's one thing. If we really want to change the population level, we need to change the politics. And we have seen great results, for instance, in other countries and also in Latin America, in Mexico and Brazil, with policies like labeling tobacco or labeling foods. And also in Chile, we have seen good results with the taxing. So the only risk factor that is lower in Chilean poor is tobacco because it's too expensive. And since we don't have tobacco production in Chile, the policy could go without opposition so much like we couldn't do that with other things that are produced in Chile. So that would be my answer. For population, you have to do population level interventions. For individuals, what you just said, I would say the individual, besides needing to be convinced, they have to have a signal for change, something very strong that makes you decide to change. The death of a family, you yourself went to a hospital. It's very difficult to change in the environment that goes in the other direction. That's what I would say. Thank you.
So I'll just.
Yes. Go ahead.
Do you want to move on?
No, go ahead.
Okay. So I'll just add a little bit from the context of changing behavior within the context of research. So the Women's Health Initiative that Dr. Newhauser and I participate in had a large behavior change trial where we randomized 48,000 women and 19,000 of them were asked to change their diet for the average of 8.5 years. And it was a substantial change in diet. And some of the tools we used were the social support of actually developing social support within groups. So that the women were learning about changes in their behavior as a group. And so even when the trial couldn't afford to provide the intensive support, we had to cut back, the women themselves could support each other in continuing this dietary change. We also needed to adapt over time as we were learning different things about what was impacting the women. And so we implemented new procedures to promote the same intervention, the same changes in diet, but the intervention was continually refreshed with techniques such as motivational interviewing or things like that to try to give sort of a bonus or a booster shot in the intervention. And we found that those were useful in maintaining it.
I don't know, Dacia, if we have time for a last question.
We do. We still have about 7 minutes left, so we have a lot of questions to get through. Nelson, ¿quieres?
Yeah.
Okay.
Natalia Santis pregunta sobre la
asks about cluster randomization. Why should we choose this randomization above the individual one?
So one would choose a cluster randomization where you think that the way to deliver the intervention is naturally through the cluster. So if you're trying to change things at the level of the clinic, then all the patients in that clinic that are affected could be that cluster. And so you might think of a new imaging technique could apply to all those patients. It's unlikely that you would use a novel drug in a cluster randomized trial, but something that would be done more uniformly to the patients in that clinic would justify the cluster randomized trial. For something that's more educational, lifestyle factors, things like that are often considered for cluster randomized trials. If you can deliver the intervention in a cost-effective way to a cluster, as opposed to an individual, then you might want to consider a cluster randomized trial.
Okay. Una consulta para la doctora Neuhauser.
A question to Dr. Neuhauser. Could you speak about models for cancer prevention in the case of Hispanic and Latin American population in the United States? I'm particularly interested in breast cancer and colorectal cancer.
So is the question about those populations in the US, I think.
That can be transferred.
Yeah.
Mm-hmm.
So that's an area where we have fallen a little bit short in the US. Some of the large lifestyle intervention studies have included Hispanic populations. For example, the Women's Health Initiative that Dr. Anderson was just talking about did have a special effort to recruit both Black and Hispanic populations. So there were special clinics that tried to over-recruit some Hispanic populations. We do have a trial that's going on right now in SWOG, S1904, that's led by Dr. Kathy Crew. And that is an intervention, and it's a cluster randomized trial where medical practices as well as patients in those medical practices are randomized to receive information about risk-reducing behaviors, especially using tamoxifen for reducing breast cancer risk in women who are at high risk. So they may have had a prior biopsy with atypia or might have had a prior diagnosis of, say, DCIS or LCIS. And that particular study, all of the materials have been translated into Spanish, and there is an effort to specifically recruit Spanish speaking patients. So that's one example in SWOG that I think will go very well. They just opened accrual in September, but I think that will go very well. Dr. Crew also did a prior study in SWOG that also specifically recruited or included Spanish-speaking participants. One of our colleagues at the Fred Hutch, Dr. Heather Greenlee, she has conducted a lifestyle intervention for Spanish-speaking breast cancer survivors in New York City. And she has just finished that trial, so the data are not yet published, but that was another effort to specifically target Hispanic breast cancer survivors in the US. And the goal of that was to improve the breast cancer patients' lifestyle behaviors regarding diet and physical activity and survivorship. And she also has a number of quality of life outcomes.
Una última pregunta para el panel.
One last question for the panel. The age for human papilloma virus for multiple subtypes could be expanded in the case of women over 40 years of age. Do you think it would have an impact on reducing the risk of cancer?
podría comenzar.
Maybe Dr. Ferraccio could start.
Well, the evidence of efficacy so far I haven't heard about a study in people over 40 years, rather less than that. But in theory, what the antibodies do of the vaccine is to prevent the entry of the virus to the epithelial cells. After the vaccine won't protect because the virus will continue to be endogenous. So supposedly a 40-year-old woman has had sufficient sexual life to have been exposed to a large amount of types of the virus that is shown by trials. So in theory, there could be a lower impact. And at 40 years, the oncogenic process probably has already started. I think it is a little bit late. That is my idea without much evidence, actually. Dr. Neuhauser, would you like to, what's your opinion?
Yeah, I'm afraid I don't have any
Yo me temo que
on that question.
no tengo nada que añadir a esa respuesta.
We are going to finish the discussion now. I think it was very fruitful, very interesting. We all learned a lot, at least in my case. Before finishing, we're going to show you a poll. Please take some minutes to answer the questions, and we see you again in 20 minutes.
Hi, everyone. While everybody's going to the break, I would like to ask Dr. Corbalon and our interpreters to please stay on. We'd like to test his audio. Thank you.
Take care.
Muchas gracias a todos.
Gracias.
Thank you, everyone.
Chao.